The following podcast is part of a certified educational activity titled All Things Considered in Psoriasis Management, looking at the role of biologic therapies in a holistic approach. Access the entire activity and complete the post-test at peerview.com/GMW860. Downloadable slides and practice aids are also available.
Hello, everyone. Welcome to All Things Considered in Psoriasis Management, looking at the role of biologic therapies in a holistic approach. My name is Dr. April Armstrong. I am Professor and Chief of Dermatology at UCLA, and I'm so delighted to be joined by one of my esteemed colleagues, Dr. Andrew Blauvelt, and I'll have Dr. Blauvelt introduce himself.
Yeah, I'm Dr. Andy Blauvelt. I'm a dermatologist from Portland, Oregon, and I spent many years in clinical research studies, and now I'm doing consulting. So I'm happy to be here also with one of my most favorite people, April.
Great. Thanks, Andy. We have several goals for us today, and these are as follows. Number one, together we'll talk about how to recognize where psoriasis is on the body in terms of their differential impact on patients' quality of life and how that may affect the decision to use systemic therapy. Number two, we are looking to explore the rationale for using biologics to prevent psoriatic disease progression. Number three, we're going to talk about how to individualize treatment plans. And number four, we're going to talk about how to better engage our patients in shared decision-making and use a team-based approach in terms of this comprehensive psoriasis management. So with that, I'll get started with the first portion, which is looking at the unmet needs and opportunities for treating psoriasis and what is beneath the surface. When we think about psoriasis, I think our understanding of epidemiology and clinical presentation of psoriasis has really evolved over time. Main focus that our field have been focusing on over the past 20 years have been in the area of plaque psoriasis. Our understanding of other subtypes of psoriasis has gained in the recent years as well. When we look at plaque psoriasis, which is the most common type of psoriasis, we see classically these thick erythematous plaques with potentially silvery scales on them. They can be thin as well, which they can appear as patches anywhere on the skin. And one of the things that we use to assess the severity of these patches and plaques include, for example, looking at the thickness of those lesions, looking at the amount of redness, looking at the amount of scaling, and also the percentage body surface area involved. But later on, I'll also talk about some of the other key factors we now incorporate to assess severity of psoriasis. Psoriasis occurs in the United States to the prevalence of around 3% overall in the adult patient population. In the pediatric population, it's a little less than 1%. And when we look at how psoriasis affects the different racial ethnic groups, there are differences here. For example, in Caucasians, the rates is a little bit higher, around 3.6%. where in African Americans, it's around 1.5%. That being said, it's important to recognize that sometimes in individuals with skin of color, psoriasis can be underdiagnosed due to some of the challenges in terms of distinguishing psoriasis from other types of skin conditions. For clinicians in the audience, I think that you probably hear a lot from our psoriasis patients with regards to their high disease burden. Not only does psoriasis affect our patients physically, but it can also affect them socially and psychologically. And we oftentimes see this in terms of feelings of anxiety, poor self-image, but also they can affect, when it affects the kids, it can affect their school performance and also affect patients' work performance as well. So when we think about the overall burden of psoriasis, it really impacts not only their physical aspect, but also their emotional aspect and their social aspect as well. Now let's dive a little bit deeper at how disease severity is correlated with the impact on patients' quality of life. We see that in patients with a more severe disease, they tend to have worse quality of life. And this is probably not surprising. And this study really helps us to understand that when we have patients who comes to the clinic who may be covered head to toe, their quality of life is likely going to be significantly worse than someone who may have more limited disease. Now, again, body surface area is not the only measure, and we'll go over some of the other factors that impact the patient's quality of life a little bit later on. We often are asked by our patients, tell me what are some of the triggers of psoriasis? Why do I have psoriasis? I think psoriasis occurs with two components that are integrally important for its initial pathogenesis. Number one is that you likely need to have a patient who is genetically predisposed to having psoriasis. And our genetic discoveries in this area has really blossomed over the last 2 decades. However, even with that tremendous progress made in understanding the genetic variants, that only still explains a certain small proportion of the different phenotypic variants that we see. So we talked about number one, the patient needs to be genetically predisposed. Number two, they may have triggers that will exacerbate or trigger one of the episodes or one of the psoriasis flares. And infection being one of the key things that can, for example, trigger a psoriasis flare. Another factor include things as trauma. We know that when psoriasis skin becomes traumatized, psoriasis can actually spread along the path of trauma. Additionally, we may have certain medications, such as lithium, that when patients with certain genetic susceptibility to psoriasis, when they take those medications, they can actually develop either new onset or exacerbation of pre-existing psoriasis. So I think, again, in a patient who is genetically predisposed, if you then take these triggers that can exacerbate the condition, that's really set the patient up for potentially more severe disease or exacerbation of disease. Therefore, it's important that we search for effective mechanisms that not only help to control the disease natively, but also minimize some of the triggers. So what are some of the unmet needs in psoriasis? Here we see a few of them outlined here. Despite of our number of treatments that are available, we note that significant proportion of patients are still untreated or undertreated. Also, even among patients who are treated, what we see is that there may be either non-response following treatment or partial response or unsatisfactory response, but also in patients who may initially have a good response, their response may wane over time. And this can lead to switching of therapies. Currently, we have few effective oral therapies available. And finally, when we think about patient satisfaction and adherence, there can be more research, in my opinion, in that area where we explore more about what factors may influence those parameters so that we can work with our patients to improve their adherence to medications. When we think about patients who have more extensive psoriasis, what we know is that even those with more extensive psoriasis, a high proportion of them may be undertreated. And what's alarmingly is that there's a good proportion of them is also untreated. So it's very important that we address some of the access issues, as well as address some of the fundamental understanding and the need for treatment in those patient populations. Another thing that we have learned recently is that for patients who have more severe disease, for example, more extensive body surface area involvement, if they were treated with a systemic medication in the first place, then typically they use either a biologic medication or oral medication. There are patients where these monotherapy may not work, and they may require a combination of both oral and biologic therapy. Now let's talk about patients with limited psoriasis, but affecting special areas. We know that patients may have 1% or 2% body surface area of psoriasis, but if that psoriasis involves, for example, the facial area, the genitals, palms and soles, or the scalp, this can, by itself, carry significant impact on patients' quality of life. Here we see the distribution based on an epidemiologic study looking at the proportion of patients who may have these special areas affected. it's very important as we examine the patients that we look at those special areas and also ask patients about the impact on their quality of life due to the involvement of those special areas. We also note that just because we discover one special area that's involved, what we see is that some of our patients may have 3 or more of those special areas that are involved. So having these multiple areas of sensitive areas involved really compound the impact on their quality of life, and which leads to us to really want to think about a therapy that is sufficiently effective enough to really address those sensitive areas. How our field comes to classify psoriasis severity has also evolved. Historically, we have classified psoriasis severity into mild, moderate, and severe based on different cutoffs for body surface area. However, this does not account for the impact on patients' quality of life or involvement of special areas that I mentioned before, or potentially past treatment failures. For example, I will ask the audience, when you look at this, these are all 4 different patients, have a total body surface area of 1% to 4%, which if we only use the BSA criteria, they will be considered mild in our historical classification of psoriasis severity. But when you look at where that's involved and really think about how this affects patients' quality of life, I posit that you probably do not think that they have mild disease. We also know that patients who have special areas involved, such as a genital area, facial, palmar-plantar, or scalp area, or nail disease, they tend to have a disproportionately greater impact, negative impact on their quality of life. And this chart shows in an illustrative manner the different parts of our body that can be affected by psoriasis, and how, for example, when we're talking about palmar-plantar disease, looking at the quality of life in those patients having palmar-plantar disease involved, they have a disproportionately lower quality of life compared to patients with involvement of generalized plaque psoriasis, for example, in the more traditional or more commonly extensor surface areas. In addition to the decrement in quality of life, studies have also looked at the likelihood that our patients would experience depression based on whether they have psoriasis on special locations. And here what you see is that if patients have psoriasis on special locations, then they are much more likely to have depression or depressive symptoms, and also much more likely to have a higher negative impact on their quality of life overall. So how can we do better? Well, a few years back, the International Psoriasis Council conducted a Delphi consensus exercise looking at how we can recategorize psoriasis severity. And in this effort, patients with psoriasis are categorized into one of 2 larger categories. They are either categorized into candidates for topical therapy, or they're categorized into candidates that are fit for systemic therapy. And so who will be considered appropriate for systemic therapy? Those are people who meet at least one of the following criteria. And this can include BSA 10% or greater, or disease involving special areas, or failure of topical therapies. So fulfillment of at least one of those criteria would allow the patient, in the eyes of these experts who have come up with this consensus, to be considered as someone who would be meeting at least one of the following criteria for consideration of systemic therapy. Now, this is really important, and I think this was an important effort to reclassify psoriasis severity. I shall say that around the world, different agencies and different payer groups, they may have slightly different criteria for classification, but I think the IPC criteria here really serves as one of the cornerstones, foundations from which we can think about this reclassification of psoriasis severity. We know that while we have focused on psoriasis, the skin component, psoriasis is also a systemic condition that affects other organs as well. And we have, for example, psoriatic arthritis, in which 1/3 of the psoriasis patients would eventually develop psoriatic arthritis if untreated, may require specialized care from, for example, our rheumatology colleagues. Also, we know that patients with psoriasis have increased cardiovascular risk factors, which may require specialized care from our cardiology colleagues or our primary care colleagues. Along with that, we also have our nurse practitioners and physician assistants who oftentimes participate and oftentimes in certain locations also lead in psoriasis management. So I think we want to ensure that when we are approaching our psoriasis patients, that they are made aware of the entire care team and the role of different providers in that care team, making sure that there's good relationship building, that we're setting reasonable expectations with regards to communication, as well as understanding the benefits and risks of the treatment, and also the timing of when that treatment is likely going to confer a benefit, and the likelihood of long-term maintenance of a certain response. And in addition to that, I think the shared decision-making between our NP and PAs and the derms and the patients is especially important, making sure that whatever we recommend, that patients have the opportunity to ask questions. And then we also address head-on what their concerns may be in the office. So with that, I am going to give the podium to Dr. Andy Blauvelt.
Right. So I'm going to start with a little bit of basic science, pathogenesis of psoriasis. This is important because we have three major classes of biologics. The original ones, which were the TNF inhibitors, or are the TNF inhibitors. And then we have IL-23 blockers and IL-17 blockers. And of course, this is a simplified version of what's actually going on in the skin. But the point being here that there's a very critical immune pathway that we call the IL-23 Th17 pathway that is involved in creation of psoriasis lesions. So IL-23, or interleukin-23, is a cytokine that is produced by dendritic cells and other antigen-presenting cells within the skin. It's produced in excess in psoriasis lesions. So patients who have a genetic predisposition to making more IL-23 will do so in response to the triggers that April mentioned. And really what that does then is that the IL-23 triggers a T cell population called the Th17 T cells, or the TC17 T cells, which are the main type of T cells we see in psoriatic lesions. And those cells are driven or fueled, if you will, by IL-23. So IL-23, I call it the orchestrator of this immune pathway in psoriasis. And then the cells that are doing the damage are the T cells by releasing a whole bunch of other cytokines that act upon the keratinocytes. And then those keratinocytes become proliferative, they become activated, they secrete more things. And then there's a feedback loop that goes back to even make more IL-23 and more IL-17. So the point being here is that 23 is upstream, kind of regulator of the inflammation. IL-17 is more downstream. It's right at the surface of the keratinocytes. And then when we think of TNF blockers, TNF is kind of involved everywhere. It's produced by many cell types. It's not as specific to psoriatic inflammation. So for example, we see TNF levels elevated in types of arthritis, in gut disease, gut inflammation. Basically, it's less specific. The 23 and 17 are really much more specific cytokines to psoriatic arthritis. And that's why we have IL-23 blockers and IL-17 blockers, which I'll highlight now. So we have a bunch of them. We have 12 now, 12 biologics approved for moderate to severe psoriasis. That's a lot of choices. As I mentioned, 4 of them are TNF blockers, 4 of them are IL-23 blockers, and 4 of them are IL-17 blockers. So we have these major categories. There have been a lot of what we call meta-analyses or reviews, if you will, of all of those biologics. and they've all been ranked based upon the efficacy of each one of them. And so here's one example of a meta-analysis done by April, where risankizumab comes out on top, ixekizumab second, brodalumab third, guselkumab fourth, and so forth. There have been many types of analyses like this to compare those 12 drugs and to give us the best ones, if you will, in each of the categories. Here's another meta-analysis that I was involved with. And here we displayed the data a little bit differently. We looked at the number of days in the first year where patients were having PASI 90 during the course of that first year, and the number of days that patients were at PASI 100 or complete clearance during the year. And here we see the same players coming out on top. We have risankizumab, ixekizumab, brodalumab, and guselkumab, the same 4 drugs. So my point is we have a lot of choices in biologics. We have a lot of efficacy data over many years, but there have been extensive analyses and reviews done, and we're seeing the same ones come out on top. My personal recommendation is to pick the top drugs, maybe the top 1 or 2 in each of the 3 classes, because you're going to be needing to probably use each of those classes in different types of patients, and then just learning those and kind of going with those. We're not advocating that you learn all 12. But this will give you some idea of what we think are the best drugs. Now, of course, when we talk about best drugs, if you will, there's what about safety? So what I just mentioned in those previous reviews was just efficacy. It was nothing about safety. So in general, I like this slide because when we think about old immunosuppressant drugs, things like methotrexate, prednisone, cyclosporin, that we really think of those drugs as being broad immune suppressants and kind of pushing down the whole immune system. When we first had TNF blockers, we did see some signs of increased risks of infection and a few cancers with TNF blockers. And so we kind of thought of those drugs as safer than cyclosporin and prednisone. They were more narrow on the immune system, but still a little bit broad, still with a few side effect concerns. Now, the good news is that the more recent biologics, IL-17 blockers and IL-23 blockers, as I mentioned a second ago, are very specific to psoriatic inflammation, much more narrowly focused. And what we get is a more safe profile with those 2 classes of drugs than we do, for example, the TNF blockers. So this should help you in terms of how to think about safety of biologics and which ones might be the best for your patients. Now, I'm going to emphasize this again because I know April mentioned it, but it's not just about the body surface area. So we want you to really consider using a biologic therapy, not only for patients with extensive disease or greater than 10%, but consider using biologic therapy for patients with disease in special areas or high impact sites. There's a disproportionate level of quality of life impairment. It's harder for those patients to clear on topical therapy, and we really do think that they are candidates for biologic therapy as well. I just wanted to emphasize that. It's a really important part of this talk, I think. Now, the other consideration, so I just mentioned skin so far. The efficacy slides I showed you there in the reviews are just about skin disease. But we know that psoriasis has a number of comorbidities. So April mentioned cardiovascular disease. Psoriatic arthritis in particular is very common. Up to a third of patients will have psoriatic arthritis. It's really important to query your patients about psoriatic arthritis because it affects how we manage the patient. It affects the choice of our drug. So if the patient has no arthritis, we would choose one type of therapy. If they have arthritis, we would choose another type. So really, really essential to ask about joint disease. Now, we know patients have other things as listed here as well, depression, sleep problems, metabolic syndrome, high risk of heart attack, and so forth. When I'm managing patients, I really kind of talk about, in the short time, usually on the first visit, I emphasize psoriatic arthritis, always ask about that. And then I do emphasize heart disease as well, because it can impact not only the quality of life, but the length of their life if they were to have a heart attack. Now, let's talk a little bit more about what we call progression of psoriatic disease. So the majority of patients with psoriatic arthritis have already had skin disease, and on average about 10 years. So there's this period of time where patients have just skin disease, and then if they are going to be developing psoriatic arthritis, it can occur at any time, but on average it occurs about 10 years after the onset of skin disease. And of course, not shown here, heart disease as well is going to take years to develop. Sort of untreated psoriasis for many years will promote the development or higher risk of heart disease as well. So we think of this as a progression of the psoriatic inflammation, not just in the skin, but internally on the joints and on the heart and therefore in other places of the body. So it really is important to kind of think of this because can we make a difference? Can we interrupt this psoriatic disease progression by intervening with our therapies earlier? So that's a key kind of question that people are looking at now. A little bit more about psoriatic arthritis. So who's going to be at risk? So we do know if psoriasis is involving certain areas of the body, for example, the nails, the scalp, intertriginous areas, if patients have more widespread disease, these are the patients that are more likely to develop psoriatic arthritis. So you can be looking out for it, if you will. Don't just ask once at the beginning. Ask about joint symptoms at each visit. It's really important because they may not have it when you first start managing them, and they may develop it over time. Now, we do think of psoriatic arthritis as sort of coming in a preclinical and subclinical stage, and then full-blown onset of disease. People with subclinical PSA may have nonspecific arthralgias and myalgias. They may have morning stiffness that lasts more than 30 minutes without frank arthritis. So those are important things to ask about as well. Morning stiffness, just any kind of joint pains. It may not be true arthritis yet, but those could be the precursors for psoriatic arthritis. Now, in my management of patients, I ask some simple questions. The most important one is the first question here is, do you have joint pain? Do you have joint pain? That is what you should be asking every patient. In addition, I think a couple other key questions to ask to get at some other things with psoriatic arthritis. One is heel pain. So Achilles heel pain is enthesitis due to psoriatic arthritis, and that's not uncommon to see. So the patients might have heel pain and then not say anything when they're asked about joint pain. So that's a question that I usually ask. And then back pain as well. So synovitis, psoriatic arthritis involving the spine is a thing. And so you need to be asking about that. And of course, morning stiffness, as I mentioned earlier, if it lasts more than 30 minutes, that's significant morning stiffness. Now, there are some studies, very interestingly, in the last several years to suggest that patients at risk for psoriatic arthritis, if they are placed on a biologic, that they can decrease the risk of psoriatic arthritis. So very interesting topic. It's controversial. There's some studies that have showed the opposite, that there is not any blockade, if you will, of development of psoriatic arthritis. And then it's interesting that the IL-23 blockers in particular are the drugs that have been shown to potentially block psoriatic arthritis. So again, now some data about blocking that progression of disease. We can make a difference if this is borne out with other studies. So very interesting data. Now, the last portion I'm going to mention is just, are patients satisfied? You know, we think we know everything. We think we know what's right for patients. We think we know what they need. But this Uplift study was very interesting in that it compared patients' views on things with doctors' views on things. And I'm just going to highlight here that patients, for example, think of the types of symptoms, the disease severity, and the lesion location when they think about disease severity, whereas dermatologists think about quality of life and BSA, or the amount of skin involvement. What's the most important treatment goal? Patients say reducing itch, whereas dermatologists say improving quality of life. Patients say symptom improvement is important, and doctors say long-term efficacy is important. And my point here with this slide is we don't always know what's best for patients. We don't always do what's best for them. We a lot of times do what's best for ourselves or what we think is best. But it's very important. I think this is the key point here is to ask your patients about their satisfaction. Ask them how they're doing. Don't assume you know. There's good data to suggest that we're often discordant with what we think and with what our patients think. So with that, I'm going to actually take us into the next section, which is going to be going over specific cases. I'm going to introduce the first case here, and then we'll have April join us again, and we'll do a little bit of back and forth. So the purpose of this session is really to maybe put some of the knowledge to work that we just have given you in terms of more of a practical way by going through some cases we think are representative of your population. So this first one, I'll present to her and see what she thinks, and then we'll go back and forth. I'll see if I agree with her. It's a 47-year-old obese individual, male professional, the BMI of 33, who presents with plaques, many plaques on the arms, legs, and scalp that have become bothersome to him. Upon examination, there's also pitting and onycholysis of the nails, but there's no joint pain. So the questions here is, how would you approach the diagnosis, treatment, basically the overall management of this patient who presents with widespread plaques, middle-aged, a heavy individual, and also with nail disease.
So I would say when I first look at this patient and really thinking about the IPC criteria of those who are appropriate for topical therapies versus those who are appropriate for systemic therapies, I will probably look at first look at the systemic category due to mainly the significant involvement of psoriasis over many parts of his body. Now, he doesn't have joint pain yet, and he does not seem to have other signs or symptoms suggestive that he may have psoriatic arthritis. So that is also informative, because in my selection of systemic therapy, I can focus on really the main consideration being skin disease. And I think that also another comorbidity that he has is obesity. And so when I think about obesity, I think it's important to also choose therapies that can work in both patients who are normal weight as well as obese. And I know that a lot of our IL-17 and IL-23 inhibitors actually have good data that it works in patients of varying weights and varying BMI. Any thoughts, Andy, in this case?
Yeah, April, I think this is a good case because it represents kind of a typical case, widespread psoriasis, no psoriatic arthritis, heavy individual, middle-aged, really typical. I think this brings up too, we didn't mention it yet, coverage. Is this patient going to have to go through some steps or step therapy in order to get the best treatment? Or can we kind of go to the best treatment? So for me, this one, I don't think you mentioned it, but would be a great candidate for an IL-23 blocker because efficacy, safety, convenience, and no arthritis. Now, if the patient would have had arthritis, I would have probably gone more towards an IL-17 blocker. So now I say that, but we all know that, there's step therapy things that have to happen a lot of times. So, but in an ideal world, that's probably how I would go with this patient.
Yeah, I think those are great points. I think either an IL-23 or IL-17 would work well in this patient. And most of our especially the ones that were developed a little bit later, IL-17 or IL-23 medications, work quite well in most of our obese patients. Unless the patient is morbidly obese, then we may see some slight reduction in terms of efficacy. But overall, I would say most of our sub-analysis of patients with different weight deciles have shown our biologics that are developed later on tend to have good efficacy in patients regardless of their weight.
And then somebody might say, do you use a certain drug if they have nail disease or not? In my experience, the best drugs work the best in the nail.
I think in some network meta-analyses, they've shown that IL-17 inhibitors, for example, one of them, bimekizumab, which is a newer generation IL-17 inhibitors, having a good nail data and possibly even nail data that may look even a little better than other IL-17 inhibitors. But larger studies will need to confirm that, but agree that most of our psoriasis medication that have good efficacy for generalized plaque psoriasis tend to have good nail data as well.
Now, one last query for you on this case. What would you expect in the long term with him? So do you think the patient would stay on the drug forever, or what would you predict how long this patient might do well, say, or how long would you wait before switching is another question, I guess.
Yeah, I think overall, if this were a treatment naive patient, in terms of systemic treatment naive, if the patient hasn't been on an oral or biologic medication before, overall, I suspect the patient will do actually quite well on the initial choice of biologic that we discussed, and likely will stay on that for a long time. I suspect that in the future, if there's a reduction in the response, likely a secondary loss where the patient initially achieved good response, then maybe after a few years, the response start to kind of taper down a little bit. If the patient didn't respond optimally to the biologics at the very start, I typically wait actually at least 6 months before I switch biologics. Unless they didn't have any response at all, then I start to question if they have psoriasis. The reason being most of our biologics, they do work and they work quite well, and they should see some kind of noticeable effect. The reason I would normally not consider switching before 6 months of time is that there is a proportion of patients who may respond a little bit later on, and most of the response curves start to plateau after 6 months. So I want to make sure I give the biologic a good try before switching to another biologic.
And then one last question on this case. I mean, obviously, there's been a lot of talk in recent years about PASI 100 or complete clearance, right? And I think we know now from quality of life data that's the best result. That we get the best quality of life if we can get rid of every single psoriatic plaque, and even one plaque, the quality of life plummets by like 20 percentage points with even a single lesion. So let's say he doesn't get to 100%, but he gets to, 80 to 95 or something like that. So tell me how you would think about either switching or maybe adding something, what you would add if you had let's say a good response, but not a complete response. What kinds of things would you talk about or think about?
Yes, I think if he has had a good response overall, and we think about the National Psoriasis Foundation treatment target of 1% or less. I think if he is near that, and let's say 1 or 2%, I would probably try to optimize his therapy by adding topical treatments to optimize that. And occasionally, if he has one stubborn, small, thick lesion, maybe occasional intralesional corticosteroid injection just into the skin itself. I think we used to think about also doubling up with biologic plus oral combinations, which we showed earlier. However, I would say these days we do have a lot of different choices of biologics. So if he responded somewhat well, but you can see he's still dissatisfied, I will probably then switch him to another biologic. And if it's a primary failure where he didn't really respond that well initially, then I'd probably switch him to something from a different class.
Yeah, another point I want to just make about the complete clearance versus near complete is sometimes if patients are near complete and have just a little bit left, we don't ask them. We just assume they're okay, and where we don't try to get rid of that, or we don't talk about changing. And I always recommend asking the patient how they feel about their remaining disease or residual disease, because some patients was, oh yeah, that doesn't bother me at all, or yeah, I have a little bit here and there. I'm doing great. I'm happy as a clam. Other people, depending on where it's at, they'll hate their single remaining spot, and they'll really want to be aggressive to get to clear. So I usually teach that don't assume that a little bit of disease is insignificant. Ask the patient what they think about it. What do you think about that?
Yeah, I think absolutely. I think that's really important. And also the area may be in a hidden area that even when we are doing full body skin checks, that it could be in a genital area that we're not aware of. So I think finding out where that's located and its impact on the patient's quality of life is important.
Yeah. Thanks.
Yeah. So I have a question for you now, Andy. So now we treat oftentimes patients with skin of color. Oftentimes, a lot of times, especially in LA, we see very diverse patient population. And I wanted to kind of get your thoughts that as you approach patients with skin of color, we talked about sometimes there could be diagnostic challenges associated with that. Would your management approach change at all with that patient population? And if so, how? Or would it stay relatively the same?
A really good question, really important question, I think. Like you, I'm comfortable treating patients with skin of color, all colors. I because of where I trained at the University of Miami, very diverse population. Didn't have any problems with that diversity and with management of patients. But it is true, depending on where the patients are in the country and which dermatologists they're going to, there are dermatologists who are out there who are uncomfortable or are not well trained, if you will, in managing skin of color. And one of the things that we have seen in those cases is sort of under assessing the severity of the disease. So the erythema, usually it can appear as redness in black skin, or it can appear as just as darkened skin, and sometimes underestimating darkened skin and not counting it as erythema or not counting it as part of the BSA. So I think my advice is to those who are managing patients with skin of color is to really look closely at the darker area skins, maybe the hyperpigmented skin, and is it active psoriasis? Make sure you're getting your body surface assessment better, and then historically, because the medical system has not been fair to Black individuals, for example, and so there is some fear, I would say more fear among Black patients in terms of just medicine in general or systemic medicines. And so I think you would have to establish a rapport with those patients, maybe answer more questions, maybe go over safety even more with them to make them feel comfortable. So because of that historic sort of wariness of medicine in general. So I think that's the other thing. So just assessment of the skin, making sure you get the severity right, and then maybe hand holding a little bit better, or talking about safety more. Make sure they're very comfortable with the treatment plan. May have to work a little bit more with individuals with skin of color. So But the drugs in themselves, I would say, work equally well. The biologics we mentioned in terms of skin color versus Caucasians. So I don't think we have to worry about, we have to use X drug instead of Y because it's a Black patient. I really wouldn't go there. I don't think we have good data in that regard. And then specifically, we have a recent study with IL-23 blocker, guselkumab, showing that it works well in patients with Black skin. And so to support that opinion. So did I miss anything? Do you have anything else?
No, I thought that's very comprehensive.
Okay, I'm going to make a new variation on you now, April.
Okay.
So I'm going to throw in a twist of now the patient is over 70. So it's a little closer to my age, not your age. But so would you manage a patient over 70 different? Would you choose particular drugs? Would you have particular concerns? What do you think about the elderly patients?
Great. Well, I think you're still a long distance away from 70, Andy, first of all. And I love this question because we see a lot of patients these days, as you know, who have moderate to severe psoriasis, who are elderly. And I think few things about the elderly that we need to take into consideration is number one is that they can have a number of different comorbidities that we need to be mindful of. And associated with that, number two is that they tend to also take a lot of medications for these various comorbidities. So this is where, for example, a choice of medication, when we're thinking about it, we need to make sure that the safety profile is good for our elderly patients, that we want to probably do in general handle a bit more gingerly due to the increased number of comorbidities and as well as a concomitant medication. And also whatever we choose, hopefully will not significantly result in drug-drug interactions. So, and so that being said, there are a number of different systematic reviews out there looking at age as a factor in terms of the different outcomes. But one systematic review, for example, after evaluating the effect of biologics in different age groups, concluded that, for example, age should not be a limiting factor in its own right. And I agree with that. I think especially for our elderly patients who may have by then a limited number of years left, we especially want to pay attention to their quality of life. And if psoriasis is something that significantly impacts their quality of life, that we want to do everything possible to augment that. So I think a conversation with our patients is very important. And then also, speaking of treatments, when we're looking at how the conventional treatments, so for example, conventional oral treatments, we think about such as methotrexate or cyclosporin, versus let's say the biologic treatments in patients greater than 65. Probably not surprisingly, our traditional oral therapies such as methotrexate have commonly been associated with more side effects because number one, those side effects, especially hepatic, is cumulative. It's dose dependent and cumulative, and psoriasis is a chronic skin disease, so the likelihood of experiencing that cumulative AEs is higher with older individuals if they started those medications earlier. Now, our newer oral therapies, I would say, have a better safety profile. So when we're thinking about deucravacitinib or Premolast in the elderly, much better safety profile, I would say, overall than our traditional oral therapies. Now, our biologic treatments overall have had really good safety profile. Data have shown in the elderly population. Now, if we just focus on this group, there's a study looking at 6 different centers. A cohort study found that usually, fortunately, serious adverse events were rare among the elderly. And if they were to occur, mostly infectious AEs, and most of them are reversible and manageable. And ultimately, the patient, once they have gotten over that infectious event, for example, can continue their biologic without long-term disruption. So overall, what was seen is that we've learned overall, I would say, the safety of biologics in patients with elderly. So I think it's actually overall very good choices for them. I'll add a minor point about also phototherapy. I think it's very inconvenient for a lot of my elderly patients to travel for phototherapy. And even with home phototherapy, oftentimes I find it's hard for them to position the panels correctly at home. And they oftentimes do living, some of them living small quarters, and it cannot accommodate a phototherapy unit and so forth. So I think phototherapy in the elderly, is a treatment option where we're seeing fewer and fewer preference for that. Any thoughts on that, Andy?
Yeah, I think add two things or emphasize two things. One is that when the first biologics came out, the TNF blockers, there was a warning about leukemia, lymphoma, and it still is in there for TNF blockers, and serious infection labeling also for TNF blockers. And so I think a lot of folks back in the day said, biologics are unsafe. They cause infections and cancers. And, I won't use them, or I won't use them in the elderly. But another main point, again, of this talk, and I mentioned already, is that the newer biologics, the IL-17 and the IL-23 blockers, don't have any cancer risk in their labeling, and they don't have a serious infection risk in their labeling. So I really, I want everyone to know that it's not just all biologics that are associated with infections and cancers. It's really the new ones are not, and I am very comfortable using it in patients with this age group. And then the last point is access. Here we're in, at least in the U.S., Medicare. Sometimes we go with whatever we can get through Medicare. Some of the drugs are more easy to get. For example, if we use them at an infusion center versus, having to pay in some other way. So there are some tricks sometimes to treating these patients in terms of access. I don't know if you have any comments about that.
Yes, I think that's a very important point. I know that, for example, one of the biologics is mainly covered through Medicare Part B, and B as in boy. So that's tildrakizumab. And so why that's helpful is that because in the United States, at least, if the patient doesn't have good drug coverage through Medicare, then they can use their medical benefit part to have a biologic be available to them. Mm-hmm. All right, so we're going to pivot a little bit, talk about pregnancy. When we think about our patients who have plaque psoriasis and who are pregnant, or importantly, many women in childbearing age range thinking about becoming pregnant, what would your management approach be in those situations? How would you advise these women who desire perhaps both control of their psoriasis and also minimal effect on their reproductive abilities?
Yeah, sure. It's there's a lot of things to consider with pregnancy. I'm going to start by saying probably the most important thing, and that's discuss it with a woman. And so have a clear conversation about where she's at, what her perceptions are of her disease, of her treatment, because you don't want to make a plan and then have her kind of disagree with the plan. So to me, this is really important, where the shared decision making that you mentioned early in the talk is really important here in case of pregnancy or a woman planning on getting pregnant. Now, the second thing I'm going to mention is certain drugs you don't use, right? So methotrexate is a drug you wouldn't use in pregnancy. Acitretin, we haven't mentioned that, an old oral drug you would not use during pregnancy. JAK inhibitors, approved for psoriatic arthritis, you would not use in pregnancy. So some drugs absolutely contraindicated. And then you want to say, well, is this patient, are you going to go systemic or topical, right? So maybe Sometimes during pregnancy, the disease can wax and wane. Sometimes it's worse with pregnancy. Sometimes it's better, just because of the pregnancy. So maybe you can get away with, for example, topical therapy or phototherapy during pregnancy and not use a systemic. But if you're going to use a systemic, if you have to, I would say that the biologic of choice right now would be a drug called certolizumab. It's a TNF blocker that actually doesn't cross the placenta. So it's an excellent TNF blocker. It's one of the best TNF blockers in terms of those rankings that I showed. And it's not going to be crossing the placenta. So that would be completely safe, I think, during pregnancy and during breastfeeding. And then, if a TNF blocker was not a good class for the patient, I personally would be comfortable with an IL-23 blocker during pregnancy, dosed infrequently. Perhaps the patient can have a long time between doses. Perhaps you can spread out the doses so there will be less exposure. We don't have as much data in terms of IL-23 blockers in terms of live pregnancies, but certainly there's no signal there, nothing coming out saying you should not use them. So those are kind of my approaches. So shared decision-making, maybe topical phototherapy, biologic certolizumab, and then maybe an IL-23 blocker. So I know it's a lot of things, but so what do you think? Anything to add?
I think that was very comprehensive. I would just add, maybe as women are breastfeeding, we do have data also showing certolizumab is not present in detectable quantities in breast milk.
April, we're going to discuss one more case, and that would be a patient who would have cancer, already a history of cancer, in the distant past, let's say beyond 5 years. So no cancer for the last 5 years, in remission, not on chemo, doing well. They come into your office, they have bad psoriasis. What would you think about this type of patient?
Yes, so we see this more and more often now as we overall actually see cancer rates on the rise for just overall general population. The way I think about it is it's two things. One is how long has the patient been in remission? And number two is whether they have solid organ malignancy or if they have lymphoproliferative malignancy. So in the case, Andy, that you highlighted is a patient who's been in remission for greater than 5 years and who have a history of, let's say, solid organ malignancy, which is most of the cases that we're going to encounter. In that patient type, in general, to date, with the available data, I would say that our ustekinumab, the IL-12/23 inhibitor, or our IL-17 inhibitors and our IL-23 inhibitors overall appear to have good safety data, such that their use does not seem to impact, does not appear to increase the rate of cancer recurrence, for example. And among them, we know that ustekinumab has been around the longest, but again, IL-17, IL-23 inhibitors overall do not seem to impact the rate of recurrence. The TNF inhibitors, I think the data was initially mixed, but overall, generally, as the long-term data continue to accumulate, they are considered, the benefit overall also outweighs the risks as well. Apremilast seems to be safe as well in the patient population, so it has been, I know, used in the real world for that. I think the key thing is to discuss it with the patient and making sure that they are aware that our data to date suggests that the systemic medications that I mentioned before do not seem to impact their rate of cancer recurrence. Now, they may have a native rate of cancer recurrence, and they should be aware of that, because as we know, if we treat enough patients, someone's going to get recurrence of cancer. We also find IL-17 inhibitors, IL-23 inhibitors, and so forth, overall have pretty good data in the population patients who recently went into remission. And just to add very quickly, my one caveat is that for patients with my personal caveat, and then I'll be very interested in hearing, Andy, if you agree or disagree, is that for patients who have lymphoproliferative malignancies such as leukemias and lymphomas, I usually, for those cases, I do work with oncologists together and also discuss with the patient together as to whether to continue or initiate biologic therapy. And then reason being that we know patients with psoriasis have natively increased risk of lymphoma. So for that patient population, I tend to really approach that case by case basis. Mm-hmm. Andy, any thoughts?
Yeah, I agree with everything you said. I think if you go back to my slide about the reverse funnel, the more immune suppressant the drug's going to be, the more I would worry about using it in a patient with cancer or history of cancer. And for me, the drugs that are more narrowly acting, those 17 and 23 blockers, are the best choices. Those are going to be the best choices, I think, in terms of a cancer patient. And I just want to say, it's another example of shared decision-making, right? Where don't assume, they have a history of cancer, I'm not going to treat you with a biologic. The patients often, in my experience, want their psoriasis treated. It has a huge impact on their quality of life, and they're willing to accept that potential risk, if you will, of cancer for having their psoriasis treated effectively. So most of patients will want systemic therapy if they need it, even with that cancer history.
I'll briefly provide a summary of our talk today. One being that psoriasis is a multi-system inflammatory disease, and it can be associated with multiple different comorbidities, including, for example, psoriatic arthritis, cardiovascular disease, depression, anxiety, and also we know that psoriasis can significantly diminish patients' quality of life, especially if they have psoriasis involving certain areas like the scalp, palmar plantar genital areas, and nail disease. And we discussed pretty extensively about when we're thinking about patients who may be appropriate for systemic therapy, that we not only take into account body surface area 10% or more, but also involvement of those special areas, regardless of the overall BSA, as well as those who have failed topical therapies should be considered seriously for systemic therapy. And finally, I think, Andy, you especially presented some very interesting data regarding early systemic intervention and how that may have a positive impact, long-term impact on patients' psoriasis and psoriatic arthritis by possibly delaying the onset of joint disease and possibly even preventing joint involvement overall. And so with that, I know that I have really enjoyed talking with you, Andy, and especially those cases and special populations that we discussed at the end. And I want to thank our audience members for being with us in our journey here. Thank you very much for your attention. Again, this has been All Things Considered in Psoriasis Management, looking at the role of biologic therapies in a holistic approach. Until next time, thank you very much.
Thank you very much, everyone.
Thank you for listening. Remember to download the slides and practice aids and complete the post-test for instant credit. This activity is certified by PVI, PeerView Institute for Medical Education. This activity is supported by educational grants from Janssen Biotech Incorporated, administered by Janssen Scientific Affairs, LLC, which are both Johnson & Johnson companies, and Lilly. To access all materials for this activity, visit peerview.com/GMW860.